Hello, everyone. Today we're going to dive into the topic of C-reactive protein, or CRP, a widely used biomarker in clinical practice, especially relevant in infectious, inflammatory, and cardiovascular conditions. CRP is an acute phase reactant produced by the liver. It's a key part of our innate immune system. When there's inflammation, infection, or tissue injury, CRP levels increase quickly. It serves as an early marker of systemic inflammation, often rising within just a few hours of the trigger. CRP synthesis is primarily driven by cytokines like IL-6, IL-1, and TNF-alpha. Once produced, CRP binds to phosphocholine on damaged or dead cells as well as certain bacteria. This binding activates the complement system and promotes phagocytosis, helping the immune system clear damaged tissue and pathogens. CRP has a broad range of clinical applications. It helps distinguish between bacterial and viral infections. In rheumatology, it's useful for tracking disease activity in conditions like rheumatoid arthritis or vasculitis. High-sensitivity CRP or hsCRP plays a key role in assessing cardiovascular risk. It's also commonly used to monitor for post-operative complications. CRP is often compared to ESR, another inflammation marker. CRP rises faster within 6 to 8 hours and is generally more specific. Unlike ESR, CRP isn't influenced by anemia or is affected by age and gender. It also has a shorter half-life, making it more reflective of real-time inflammation. High-sensitivity CRP is used primarily for cardiovascular risk stratification. A level below 1 milligram per liter indicates low risk. 1 to 3 suggests intermediate risk, and over 3 indicates high cardiovascular risk. It's especially useful when combined with lipid profiles and other risk factors. In rheumatology, CRP is elevated in diseases like RA, psoriatic arthritis, and giant cell arteritis. However, in lupus, CRP can remain normal despite active disease due to the unique way lupus modulates cytokine expression. This makes context and clinical judgment essential. There's a broad differential for elevated CRP. Bacterial infections, chronic inflammatory conditions, trauma, and malignancies can all cause rises in CRP. Obesity and smoking may lead to low-grade chronic elevations. So it's important to consider both acute and chronic triggers. CRP levels can guide our interpretation. Normal is generally under 1 milligram per liter. Mild elevations up to 10 may reflect low-grade inflammation, while levels above 100 are more suggestive of severe infection or systemic inflammation. Again, context is everything. Despite its usefulness, CRP is not a disease-specific marker. It can be elevated in non-pathological conditions like pregnancy and may not rise significantly in some autoimmune diseases. Also, CRP levels can lag behind clinical improvement or deterioration. To summarize, CRP is a valuable and versatile biomarker. It's fast-responding, relatively specific, and helpful in a variety of clinical settings. Whether you're assessing infection, monitoring autoimmune disease, or stratifying cardiac risk, CRP offers important insights, but always in conjunction with the clinical picture.